the first piece that we had it was really based on clinical practice from the UK, and it's still incredibly powerful today, was actually how it was being used by doctors who've been using it. This paper, I don't know how many years old it is now, but what we found was there was three things. One, people were using it to make a go, no go decision on when to use inhaled steroids in people with vague symptoms. Two is a bit of an adherence support. So when seeing patients who are poorly controlled with their asthma, and people were not sure when patients said they were adhering, and yet their FeNO was sky high, people would go, no, you can't really be taking your inhaled steroids, and actually showed an increase in adherence after that. So I think those were the biggies for me of the gain from that original real life research. Now we've done rather more interesting things since then, and one of those was a retrospective study looking at people's current asthma control and their prior exacerbations versus their FeNO and blood eosinophil count. And what was really interesting there is that they were both independent predictors of the risk of exacerbations of asthma. So clearly very helpful in determining risk. Then I think the piece that I found the most interesting for me was supported by an academic grant from Circassia, where we randomized patients to inhaled steroids or placebo who had what we called non-specific respiratory symptoms. These are people with cough, wheeze, shortness of breath, but without objective reversibility supporting a diagnosis of asthma. So these are the patients where you're saying, do I give them a trial of inhaled steroids, don't I? And what we saw was that there were two independent predictors again of response, FeNO, strongest predictor, but also blood eosinophil counts, independent, and both predicting symptomatic response to inhaled steroids over placebo at 1 month. So clearly a very good signal on predicting who would symptomatically do better. So I think that was very powerful for me in saying, you got this patient, you really don't know what's going on with them. Well, this is a great way to work out whether you need to give them inhaled steroids or not. So those are the biggies for me. There are other pieces of work that are we had a pediatric study which sadly has not been so clear cut. We did try and do it was government funded in the UK, where we randomized people to personalized management of their asthma according to their FeNO. The trouble was these were all patients in severe asthma services for kids. And they were pretty much at the top of the dose response curve for inhaled steroids. So there was nothing really to be gained, I think, from increasing their therapy further. So both groups got big improvements, and difficult to ascertain where the FeNO assists in that particular position. Certainly the adult studies would suggest it's also very helpful in predicting who's going to respond to higher doses of inhaled steroids. And then I guess the final pieces of evidence are those that are coming through from our international severe asthma registry, where we've got an algorithm that looked at eosinophilic asthma, and by looking at both, we used eosinophil counts and FeNO as part of that algorithm. And what the big message for me was that only about 5% of people with severe asthma were non-eosinophilic, if you include FeNO within that definition. So the vast majority of people with severe asthma have what we might call T2 disease. So disease that is going to respond to T2 therapies. So that's both inhaled steroids, but also our biologic therapies too. So I think that's, for me, some of the key real life studies.